next I welcome Dr. Harshul from Jaipur. He's a prolific cataract and refractive surgeon, and he would be talking on toric IOL refractive surprises. So how do we manage ahead that we have implanted a toric IOL and now the result is not optimal? Thank you, sir. So what to do next? How do we evaluate this and how do we correct this?
Thank you so much, Dr. Vanashri. So can I have my... Okay, right. So before I start, I'd like to show two slides here because this topic is so close to my heart. So this is the way, as Dr. Rajesh mentioned, and for the benefit of the youngsters, that how do we mark on slit lamp. So I just want to show one video here. So always keep this slit beam horizontal and make it very thin. If you can see here, this is a 26 gauge needle which I'm using. Because if you directly try to mark with the ink pen, it makes almost which is 5 to 7 degree. It's thick. So this is a 26 gauge needle or 30 gauge needle which you can use. So narrow down on slit beam, and you can see I'm scratching on the corneal epithelium here. So once you have put these scratch marks on the epithelium on both the sides, the advantage is even if your ink mark fades, these scratch marks will remain when you take the patient in OR. So once you have made these scratch marks here, then go and put some ink on the tip of 26 gauge needle. So the advantage is you get a very thin mark there, and as well as you get a scratch marks on epithelium. So this is the first thing which I wanted to share with you. And next is we are talking about implantation of IOL. So what I described in 2010, the technique of hydroimplantation, and I coined this term, and this technique is very useful in toric and multifocal and trifocal cases, because we all know that if we have any residual OVD leaving behind the IOL optic, it may cause post-operative rotation of the toric IOL. So we should always try to use this technique, hydroimplantation. So you go ahead and put irrigation cannula in the anterior chamber on the irrigation mode. So once you have this irrigation cannula, it maintains the anterior chamber depth as well as capsular bag. And when the IOL is unfolding, keep the tip of the irrigation cannula over the IOL optic. So this is a mistake which many surgeons do, and I see a lot of videos that just keep irrigation cannula here at the side port incision. So this IOL, when it's unfolding, it may rotate, it may flip. So if you keep this irrigation cannula tip over IOL optic, it will not let this optic rotate. So once you have the IOL in capsular bag, see it's very well maintained. So use Kugelens hook to put the trailing haptic in the capsular bag. And it's very important that you have a perfect size of capsular axis. So here, this axis is smaller in size. So when you're talking about the final alignment, so before you do final alignment, this is the mark where you need to align. You need to enlarge the axis to desired size before aligning it. So again, just put irrigation cannula there and you can enlarge the axis to desired size. And after that, just under irrigation, you go ahead, use Kugelens hook. And these are the marks where we need to align the toric IOL. And you go ahead and align the lens. So, and this is the hydro stitch cannula which I have designed. So you go ahead and put IOL in the right place and just hydro stitch all the incision, and you have IOL perfectly at the perfect location. So these are a few tips I wanted to give about this, but we may have surprises in post-operative period. So let's see how do we tackle those surprises. Okay. So we all know that even small errors in position of the toric IOL may significantly affect the patient uncorrected visual acuity. So what are the causes of the toric IOL surprise? Firstly, that there is a pre-operative measurement errors. You didn't measure the keratometry perfectly, axis perfectly. There may be problem in incorrect in the marking of the reference points of the cornea. So you should always check whether your 0 and 180 marks are in the proper plane or not. So it may give rise to toric IOL surprises. And if you have not placed the IOL correctly, suppose there is, by mistake, you have done wrong calculations and you have placed the IOL in the wrong axis, or you have failed to take into account the effect of post-corneal astigmatism or your SIA, or there may be problem in the IOL placement, of which because of the tilt there may be surprises. So we all know that how to check the position of toric IOL in post-operative period. We dilate the pupil and we narrow down the slit beam and align it to the toric IOL marks which are there. So once you align these marks, so on slit lamp there is a angle which you can make out using this, or this is the optical biometer OA2000 which I use. So it captures the image like this, and it gives me at the difference of 1 degree that what is the IOL axis as compared to the reference axis. So when I check on this, so this is my reference axis and this is the IOL axis. You can rotate it at the 1 degree. So here it shows that IOL axis, this is the yellow one, it is at the 87 degree. Even though this is the photograph which I have taken, you can't make out clearly the toric IOL marks here, but you can easily make out when you see on that screen. So what are the options we have if we have post-operative toric IOL refractive surprises? That we go and do some calculations online, which I'll be showing. If those online back calculators gives us that the rotation of the IOL can cause reduction of refractive cylinder, we go ahead and do rotation of the toric IOL. If those calculators show that they won't have any effect on the post-operative toric IOL surprise, then we have an option of exchanging the IOL or putting a piggyback IOL of residual refractive error over the existing IOL. And if we have large magnitude and axis problem, then maybe LASIK or PRK we have to do in these kind of cases. So this is the online toric calculators. This is astigmatismfix.com, which is developed by Badal and Hardin. So what essentially you need in the data which you need is what is the current refraction of the patient right now, and what is the IOL axis where the toric IOL right now is sitting. So if you feed on these data, this calculator give you the rotation which is required to correct the residual cylinder. This is the ASSOT toric calculator, which also can be taken help from. The same data is fed in all these type of calculators. So these are various calculators. Even Barrett has Barrett RX formula, which can tell you whether you need to rotate the IOL or you need to put a piggyback IOL or need to exchange the IOL. So I'll just share one case here to make it very easy for you to understand. This was a referred case on 12th day post-toric IOL surgery, and patient had uncorrected vision of 636, and his refraction was -1 sphere and plus 2.5 cylinder at 140 degree. So with this refraction, patient was reading 6.6, and this was the surgeon told me that the T6 IOL was placed at 10 degree. So this is the data which I have, and the patient is very much dissatisfied because of the vision which is very poor. So I go ahead and dilate the patient and check. So we go ahead and check where the IOL toric IOL is now sitting. So I go ahead and check that yes, it's 10 degree. So toric IOL where the surgeon implanted at 10 degree, it's at 10 degree, but still he has a refractive surprise. So I go ahead and check on optical biometer. It's showing me that IOL is at 10 degree, IOL axis. So I go ahead and use this online calculator. So if you can see, I feed in here that what is the toric lens and axis, what is the current refraction. So I feed in the current refraction. So what this calculator shows me here is the ideal position of the toric IOL has to be 175 degree. So it gives me the data that I need to rotate my IOL from this blue line, this blue position to this position of 17. So I need to rotate it in clockwise direction 15 degree. And this will reduce the cylinder to minimum of 0.24. So now this calculator has given me that I need to rotate it 15 degree in clockwise direction to reduce down the cylinder. So this is how we calculate that what is needed. So I go ahead and see how this case was done. Now we don't need to mark the reference axis here because these IOL marks are acting as a reference axis, and we just need to go 15 degree in clockwise direction from here. So I go ahead and put align 0 and 180 degree to these toric IOL marks, and using these I mark on both the sides 15 degree in clockwise direction. And after marking, I go ahead and this is 14th day, that is 2 weeks after the surgery. Go ahead and just put irrigation cannula through side port. So I opened up the same side ports there and just use Kueglen's hook. I go beneath the anterior capsular axis margin, separate it from the IOL. So we don't need any OVD here to rotate this lens. Just put irrigation cannula there. Use Kueglen's hook to rotate the IOL. So now we have IOL which has been rotated 15 degree to the desired axis here. And this finishes the case. So in the next post-op day, you can see the IOL which was there, it has been rotated 15 degree, and patient had uncorrected vision of 6.9 and best corrected with 6.5 with minus 0.5 cylinder. So this is how you can use these calculators to tackle any post-operative toric IOL surprises you have. So thank you very much for
Thank you so much, sir. That was a wonderful demonstration of how we can tackle with these surprises. I think that will allay our fears quite a lot because that gave an insight into how we can use the online calculators to find out where things have gone wrong. Is it the IOL which has rotated, or is the power calculation wrong? And we can take corrective steps and have a good outcome.
Can I ask
Yes,
a
sir.
question?
Yes, sir. Sure.
Yes, yes.
Harshul,
Yes, sir.
what is the ideal time to rotate a IOL if your axis is not correct? Number one.
Yes.
So before the adhesions develop, or you have to give some time also for the lens to settle down. So what is the ideal time? Number one. Number two is that if you have a bilateral patient, you've operated one eye and you landed up with a rotation, and the patient had a very small pupil, so it was not possible on the table to correctly put the IOL. Now you are planning the second eye. Would you like to do the second eye after 2 weeks, then do the rotation, or first would you like to rotate the lens in the correct direction, see the result, and then go ahead with the other eye?
Okay. So
And
there are
this
so
is a multifocal lens.
yeah, whatever.
Extended depth, whatever.
Yes. So there are
So
so
happy.
yes. So I think the best time to rotate the toric IOL, it depends on, suppose you have a patient on first post-op day, you see that patient is highly unsatisfied, your own patient. You go dilate the patient, check that there is gross misalignment. If you find that there is gross misalignment, that can only happen, believe me, nowadays because of either flipping of axis or your calculation have been grossly wrong. Rotation of IOL, I think with these lenses, newer lenses, is not an issue. In these lenses, rotation is not an issue, and especially I use hydroimplantation. I hardly see any rotation in these lenses. So if there is a flipping of axis, suppose your assistant has totally flipped the axis, they have calculated, you have to go ahead and do on the very next day. You can't wait for that lens to rotate on its own or whatever. So you know that it's 90, it's 180. So you have to change and